All right, welcome everyone. Thank you so much for joining us for today's webinar. My name is Mary Grace, and I'm a program manager at the Center of Asian Health Equity, and I will be your moderator today. So the Center of Asian Health Equity, or KE, is a partnership between the University of Chicago Medicine and the Asian Health Coalition, which is a nonprofit organization focusing on improving the health and wellness of Asian, Pacific Islander, African, and other immigrant communities of color through advocacy, technical assistance, education, and research. We work with community-based organizations, community health centers, and local health departments, taking a collaborative partnership approach to support the development and implementation of culturally and linguistically appropriate health programs and initiatives. So one of our pillar programs is hepatitis B. The Don't Let Hep B Win program, launched in 2013, works with multiple partners, including community leaders, community-based organizations, health departments, and community health clinics across Illinois to increase awareness, education, and linkage to care for hepatitis B. Since December 2013, our program has educated over 54,400 individuals, and over 13,000 people have been screened, which is great. All of the efforts are currently funded by the Illinois Department of Public Health, Gilead Foundation, and the Office of Minority Health. A few reminders before we get started. This webinar is being recorded and will be posted to our Asian Health Equity YouTube channel. The link will be shared out, so you can feel free to go back and listen to the webinar and share the webinar with your colleagues. There is a Q&A section at the bottom of your screen where you are free to type your questions. If time allows, at the end of the webinar, we will ask our speaker to answer them. If we do not have time to get to the questions, we will send a follow-up email after the webinar. And of course, if you have questions after this webinar, feel free to email us at hpvinfo@asianhealth.org. Now it's time to introduce today's speaker. We are so thankful to have Dr. Sonali Paul with us today to talk about hepatitis B. Dr. Paul is an assistant professor of medicine at the University of Chicago Medicine and liver transplantation specialist at the Center for Liver Diseases at University of Chicago Medicine. As a hepatologist, Dr. Paul specializes in the care of patients with liver disease, with a particular interest in hepatitis B, autoimmune, and cholestatic liver diseases, and liver transplantation. She is also an active researcher with a focus on evidence-based medicine and patient-centered outcomes. So with that, I will stop sharing, and Dr. Paul, you can feel free to share your screen. Thank you.
Great. Thank you so much for having me, Mary Grace, and everyone, and for the invitation. So I'm going to share my screen here. Can you see that okay?
Yep.
Perfect.
You're good.
Okay. So I'm going to be talking about a little bit about hepatitis B. We'll talk about kind of screening and epidemiology and treatments, and then talk about cultural humility and competency as well. So we'll talk, so kind of what I mentioned already. So epidemiology, risk factors and screening. We'll talk about serology and diagnosis, which can be of all the hepatitis viruses. This is probably the most tricky one. We'll talk about treatment, prevention, and then the newest recommendations for vaccination for hepatitis B, and then really how to have culturally appropriate conversations and foster cultural humility as well. So hepatitis B is actually the only DNA virus, so there are, hepatitis goes from A, B, C, D, and E, and Hep B is the only DNA virus. It might be the one reason why it's so hard to cure, unlike hepatitis C, which is an RNA viruses. There are a lot of serotypes and genotypes, which aren't really as important as they are for hepatitis C, or at least were for hepatitis C. But we just know that it's a DNA virus, and it's the only one that's the DNA. The thing though with hepatitis B is that, like anything that irritates the liver, over time it could lead to cirrhosis or scarring the liver, and then that's what you kind of see here in the middle panel. It can cause fibrosis prior to that, and then cirrhosis, which is scarring of the liver and impaired liver function, and eventually this can lead to liver failure and the need for liver transplant. Anyone that has cirrhosis in general, hepatitis B or otherwise, is at risk for hepatocellular carcinoma or liver cancer. And this can develop after years when folks that have cirrhosis. What's unique about hepatitis B though is that the liver cancer can develop even in the absence of cirrhosis, which is very unique to this virus, and it's because the virus itself is carcinogenic. And so that this is even more so important because when, as a hepatologist, we certainly see patients that have cirrhosis, but we may not be seeing, patients that don't have cirrhosis, but other liver diseases like, kind of simple fatty liver. Those patients are okay, but anyone that has hepatitis B really needs to be screened every 6 months for liver cancer, which is really important. So in terms of prevalence, you can see in the States and Canada, the prevalence is actually pretty low. So this is a prevalence of surface antigen, which is a marker of infection, and active infection. So not so much a problem in the States, but if you look at Asia, Africa, and even Eastern European countries, much higher prevalence of hepatitis B. So while we may not see it as much in folks that were born here, knowing kind of where patients are from and their origins is really helpful because then you can screen patients for hepatitis B. This is a great kind of just exercise in that vaccines really do work. So if you look here, so in the 1980s is when we kind of knew about hepatitis B, and the vaccine was actually, or rather in the 70s, late 70s, we knew about hepatitis B. And the vaccine was licensed in the early 80s. And you can see this is the incidence of acute Hep B in the US per 100,000. So kind of in 84, it kind of peaked. And then what was interesting was we started screening pregnant women because a big mode of transmission for hepatitis B is vertical transmission, so from mom to baby. And once we started screening pregnant women in the late 80s, early 90s, we started routinely giving infants the immunization for hepatitis B. So regardless of whether the mom had Hep B, any infant that was kind of born in the late 90s, or rather early 90s, was given a hepatitis B vaccination. And then I was actually born in 1982, so that didn't really apply to me. So I actually got, when I was a teenager in the 90s, I got my hepatitis B series for school and college as I went through. So really, but you can see that as we kind of knew about the vaccines and we started screening people, the rate of acute infections decreased dramatically. So risk factors for hepatitis B, it's really blood-to-blood transmission for the most part. So sexual contact is possible, blood-to-blood, so blood transfusions, needles, people who inject drugs. Men who have sex with men is still considered a risk factor, although I don't necessarily know if that's as high as it is. And then anyone with household contacts, and then vertical transmission, as I mentioned. So, transmission from the mom to baby. So I kind of briefly touched on this. So screening for hepatitis B is very important. So we really want to be able to know who our at-risk patients are because the current recommendations are not actually universally screening everyone. So the at-risk patients, though, are those that are coming from endemic areas, so Asia, Africa, Eastern European populations, and then persons who inject drugs, men who have sex with men, sexual partners of patients with hepatitis B. So that's a huge thing. Anytime I see anyone with Hep B in my clinic, I make sure that their partners have been tested and their children have been tested for hepatitis B and then vaccinated if they're not vaccinated. Anyone that has hepatitis C or HIV co-infection for lots of reasons. For HIV, a lot of the treatments for HIV also incorporate treatments that would treat Hep B. And then hepatitis C screening is important because if they're co-infected with hepatitis B and hepatitis C, there's a theory that there's a kind of dominant virus. And so usually if it's hepatitis C and you eradicate the hepatitis C and you cure it, the hepatitis B can flare. So it's really important to know whether they have hepatitis B if you have Hep C or HIV. Hemodialysis patients, I think our dialysis centers do a really good job of screening our patients for hepatitis B, mainly because of the use of the machines and knowing that before someone gets on their dialysis machine. And then pregnancy, our OBs are also very good at screening during pregnancy and then referring those patients for therapy if needed. And then the last one is really anyone that's getting immunosuppressive therapy. So this is folks that are getting chemotherapy or stem cell transplants. And I'll talk about this a little bit later, but hepatitis B actually integrates into the hepatocytes, into the liver cells. And so anyone that gets chemotherapy, the immune system can get suppressed, and then the hepatitis B can reactivate and cause havoc on the patient and cause sometimes liver failure. And these are kind of screening at-risk patients. In my practice, just because I am a hepatologist, I screen everyone for hepatitis B, mainly because I see a lot of patients that have abnormal liver tests, and I always want to be sure it's not hep B. But anyone that has or rather chronic liver disease should be protected against hepatitis B because we have a vaccine. So my practice is really to screen everyone, because if they're not vaccinated, they should get vaccinated. And then in terms of kind of what test to order, so surface antigen is really the test that we want to look at the most, because that's going to tell us whether they have infection or not. Is this kind of a chronic issue or not? There's a core antibody test with either, there's two types of core antibodies. There's an IgM test and then a total core antibody. So IgM, just looking at kind of basic immunology, usually means an acute infection. So this is usually positive when they're in the acute phase of infection, usually within 6 weeks. And then there's the total core antibody, which is more kind of for chronic infection. And then there's surface antibody, which is also a test you can send. And that will tell us whether one of two things: either someone's never been infected if their surface antigen is negative, and they develop surface antibody. This usually means that they've been vaccinated, or some people are lucky enough to lose their surface antigen when they get infected and develop surface antibody and essentially be quote unquote immune. And so just looking at the serologies a little bit more in detail. So the surface antigen looks at acute and chronic infection that I mentioned. The IgM core antibody is acute infection, usually within 6 to 8 weeks. There isn't, so it's the IgG core antibody, but also it's really a total core antibody because no lab will check it for an IgG. But this really tells us if there's been an infection somewhere, either in the past, when they've cleared their infection, or they were presently infected. There's the hep B surface antibody, which denotes immunity. And then the most confusing are really E antigen and E antibody, which are markers of infectivity, which we won't really talk about too much. It took me until I became a fellow in transplant hepatology until I fully kind of understood the E antigen status. So just kind of looking at serologies, and this is why I think makes hepatitis B so confusing, because there's so many different combinations of what you can have. But if everything is negative, so their surface antigen, their total, their IgM, and their surface antibody, it means that they've never been infected and there's no evidence of immunization. On the flip side, though, if their surface antigen is positive and their core total is positive, that means that it's a chronic infection. And we know it's chronic because their IgM is negative. And then we know it's an acute infection if their IgM is positive, with the other two being positive as well. And then this is one where the surface antigen is negative, their total antibody is positive, which means that they have been exposed or previously positive to the virus. Rather that they've been exposed to it, or they have chronic infection, but we know they don't have chronic infection because their surface antigen is negative. And then their IgM is negative, so we know that it's not an acute infection, and they've developed surface antibody. So this patient's been recovered from past infection. And the chart here says immune. I don't necessarily like that word because patients with hep B are never really immune because they can always have past infection. And it's mainly because the virus integrates into the hepatocyte. So even though they've lost their surface antigen, there's still 1 or 2 strands of hepatitis B kind of sitting in the liver. And then if everything is negative and the surface antibody is the only thing that's positive, it's going to be, that means that they're immune after immunization. So just in terms of diagnosis, looking at kind of the levels and trends and the time course. So within about a month of infection, the surface antigen will start to rise. Eventually, they'll develop core antibody, and this is the IgM that starts to wane as they kind of become into the chronic phase. And then this is where they'll develop HBV DNA, or kind of the viral load that we talk about. And then in terms of chronic infection, kind of similarly, after months of this, their surface antigen is positive continuously, and their core IgG is positive kind of continuously. They've lost their IgM because this is now chronic, and then they still have DNA. This is a really important point that's a little bit subtle, but the risk of chronic infection increases the younger you get the infection. So as a neonate or an infant, especially this is during vertical transmission, babies' immune systems or infants' immune systems are not very robust. And so if they get infected with hepatitis B, their immune system won't be able to clear it, unlike an adult who has an immune system and is much more robust. And so if an adult who's not vaccinated gets hepatitis B, they're much more likely to have their body kind of spontaneously clear it without any medications, and decreases the risk of chronic infection. And so this is why it's so important to really kind of target pregnant mothers and figure out ways to decrease transmission to the baby. And then when the baby's actually born, you want to decrease the risk of hepatitis B being chronic in that baby as well. So in terms of screening, this is for liver cancer screening. So patients that have hepatitis B need lifelong liver cancer screening, even if they're don't have cirrhosis. These are from our AASLD guidelines, which are our Liver Society guidelines. Technically it's for those that are surface antigen positive. And if you're an Asian male greater than 40, if you're an Asian female greater than 50, you should get screened for liver cancer every 6 months. Anyone that has cirrhosis or family history of HCC, and then anyone that's actually Africans over the age of 20 are incredible risk for HCC. It's because one of the genotypes of Hep B is more prevalent in Africa, and it's much more prevalent or much more carcinogenic than the other genotypes. And so that's actually really important. And I can't tell you how many 30-year-olds have come to me with metastatic liver cancer that we can't really do anything with. But the caveat of what I do in my own practice is that I actually screen everyone. I don't have race or ethnicity cutoff, except for the Africans, everyone over the age of 20. But once I see hepatitis B, I don't really, I don't think they have to be Asian necessarily or greater than 40 or 50. I tend to screen everyone with ultrasound or some sort of CAT scan or MRI every 6 months. And then, so ultrasound or MRI, and then alpha fetoprotein is a blood marker of liver cancer that we'll send as well. So there are different stages, and this slide isn't as important, just to kind of show you and walk through the different things that can happen with hepatitis B. So most folks will start off, especially if they get it as an adult, they'll be immunotolerant. So their surface antigen is positive, the viral load is very high. They have an E antigen that's positive and an antibody that's negative. If you biopsy them, they'll actually have normal liver kind of parenchyma. There'll be no inflammation. Their ALT, which is one of the liver tests, is normal. And these patients you can actually watch, because most of the time they should be able to seroconvert and develop surface antibody and lose their antigen. But some of those patients will actually turn to immune active. And so that means folks that are surface antigen positive, their DNA is very high. They have an E antigen, no E antibody. Their ALT is elevated. And if you biopsy them, there's some inflammation as well. And these folks have about a 2 to 5% annual progression to cirrhosis, and an increased risk of liver cancer. So these patients actually need to be treated. And we will talk about treatment kind of on the next slide. And then about 8 to 12% of those per year will develop to be an inactive carrier. And these are great because they still have surface antigen, but viral load becomes very, very low, and they lose their E antigen and develop E antibody, and their ALT is normal. And if you biopsy them, there's no inflammation. And so these patients you can kind of watch, not have to worry about. But the only worry with them is that about 25% of them will develop exacerbation of their hepatitis, and actually their E antigen will go back to being positive, and they'll lose their antibody and have like almost a reactivation, inflammation, or an activation of their hepatitis B that you have to actually treat. And then our holy grail of what we want in hepatitis B patients is losing that surface antigen and developing surface antibody. You want that DNA to be undetectable. And then the E antigen to be negative and develop E antibody. And if you were to biopsy them, that'd be normal. So that's kind of the holy grail of what we want all of our hepatitis B patients to have. Unfortunately, especially folks that get vertical transmission and are infected as kids, it's much harder to see that. And then there is this entity called E antigen negative hepatitis, and this is why hepatitis B is so confusing. So it's basically a mutation in the pre-core region of the virus, where it almost looks like the E antigen turns negative, the antibody is positive, and so you're like, oh, they're probably an inactive carrier. But then when you check their viral load, it's actually very high. So this is an E antigen negative hepatitis. It's important to recognize this because they're at increased risk for progression to cirrhosis and risk for liver cancer. So these are folks that you really want to treat as well. So in terms of goals of therapy, surface antigen loss is really our main thing. So this is the holy grail, but unfortunately only happens about 3 to 5% of the time. Sometimes it'll happen spontaneously if it's an adult that gets infected with a robust immune system. Otherwise, with medications itself, it happens very, very rarely. I've been treating hepatitis B since I was a GI fellow. So that was in 2008. I started my fellowship. And I haven't had one patient, no, 2011, I'm dating myself. I haven't had actually one, I've only had one patient that's actually lost their surface antigen on therapy. So it's very rare. The second thing that we look for if we know that surface antigen loss is not really going to happen is having their E antigen positive turn into negative and develop an E antibody. So that's called seroconversion. This has happened a fair amount, and I see this often. Not often, I'd probably say 15, 20% of the time. The problem is there are E antigen negative patients that we talked about that have the E antigen chronic hepatitis. There's no kind of endpoint for them because we know that they're most likely not going to lose surface antigen. And their E antigen is already negative. So these are the patients so we don't have another marker to go through. So these are patients that we usually commit to long-term, kind of lifelong heavy DNA suppression and lifelong therapy. So it's very much a conversation because a lot of these patients are very young. They might be in your 20s or 30s. And some of them may want to have kids down the line and may not want to be on medication to have that. So it's a conversation that is very much with patient and their physician and provider. So in terms of treatment options, so there are nucleoside tied analogs that really aren't used anymore. So those are lamivudine, tobevudine, and islatravir. Unfortunately, there's a lot of resistance. So basically the virus gets really smart and stops working with these medications. And so we don't really use them at all. Entecavir is really the first line of treatment if they're treatment naive, so they've never been exposed to a medication for Hep B. And then there's tenofovir disproxyl fumarate, or TAF, which is kind of a substrate of regular tenofovir. And we use this when folks have either been exposed to lamivudine, which is the most common medication in the past that was used, or they've somehow developed resistance to entecavir, which is incredibly rare, or in pregnancy, which we'll talk about. So the guidelines are a little kind of bizarre for hepatitis B in pregnancy. So they say to treat only if the DNA level at the third trimester is greater than 200,000. And tenofovir is really preferred, but tobevudine can be used. My only kind of thing about this is that, like, if I was pregnant and had Hep B, and my viral load was 200,000, like my first trimester, I would want to be treated because we know that the lower the viral load going into the delivery, the less chance that the baby's going to get infected. So again, even though these are kind of the strict guidelines, even if my DNA was like 50,000, I'd still want to be treated kind of at the start of my third trimester. So I very much have a conversation with the mom and the parents about this and kind of what their preferences are. Because even though we have a guideline, I still think very much it's a patient kind of centered decision that we make together. But most importantly, the baby actually needs hepatitis B vaccine at birth. And also hepatitis B immunoglobulin. And so these are the two things that protect the baby tremendously, in addition to getting the viral load down in the mom. And by doing this, the WHO had this initiative in Asia and in Africa and other countries, and it's actually decreased the rates of vertical transmission dramatically. So it definitely works. And in the States, they're very good about doing this. And for me, the onus is on me as a hepatologist. I actually write out a note to my patients that they keep in like kind of their overnight bag, just in case they ever get admitted to a hospital that doesn't really know them for their delivery. At least then the pediatricians and everyone kind of knows what the baby needs post delivery. So just a word on kind of viral replication, and I have mentioned this before, but once exposed, DNA of hepatitis B is actually integrated into the liver cells or the hepatocytes, even if the virus is cleared. So even if your surface antigen is negative, and you've developed surface antibodies, some protection, you're not entirely always protected, unlike the other viruses like hepatitis C. Once you cure hep C, it's gone. And so here you have a patient who has chronic or resolved infection. You can see that there's the X's represent the DNAs. The DNA level is kind of in the blood, in the liver. But this really becomes important when you suppress someone's immune system, because right now with these kind of three little particles, if the immune system is active, it's keeping these three particles in check. But what happens when you give someone immunosuppressive, their immune system goes down. And now those three particles turn into 9, 10, 15, a million particles, and the hepatitis B reactivates. And this is a huge problem. I've seen patients die from liver failure in this setting. And unfortunately, sometimes, a lot of the time, because the immunosuppression is for cancer, so it's chemotherapy for cancer, they become not transplant candidates because their cancer is so soon or so aggressive. And so, I've seen this kind of up front. And so, I'm very kind of cautious in terms of when I see patients like this, or, we have a lot of our oncology colleagues. And so, educating them about screening for hepatitis B universally, because no one's going to go to you and say, I have risk factors for hepatitis B, especially when you're sitting, in an oncologist's office and they have cancer and it's a new diagnosis and there's so much else going on in that room at the time. I don't even think I would know what my risk factors were for anything at that point. So, so really important to kind of universally screen these patients if they're going to get immunosuppression. So immunosuppressive drugs can increase this hep B replication. It can cause liver failure and death, and also interrupt anti-treatment. So once the liver tests go up, sometimes they have to stop chemotherapy because there are protocols in terms of when, kind of safety measures of when they need to stop and make sure the liver is doing okay. Reactivation rates can be all the way between 15 to 80%. But the good news is that if you screen patients and you know they're surface antigen positive, you can put them on prophylaxis. And so it can lower the reactivation rates to really 0%. I mean, if someone has chronic hepatitis B and you put them on entecavir or tenofovir during their chemotherapy, they shouldn't reactivate at all. So then in terms of vaccination, so we want to vaccinate any adults of any age who are at high risk for hep B infection. So routine vaccination is routinely recommended for infants, so birth to 1 year. And usually most infants will get it, at least the first dose before they leave the hospital in the States. But as I said, that was kind of introduced in the 90s, kind of routine vaccination. And so there are these other risk groups that we want to target for hep B vaccination. And so those with chronic liver disease, hep C, HIV, any kind of percutaneous or mucosal risk for exposure, like drug use and household contacts, and folks with diabetes, the discretion of the treating clinician, folks that are incarcerated, and then sexual exposure risks, and then traveling to countries that are high endemic areas, either 8% or intermediate 2 to 7% of hep B infection. But in March of 2022, so just a few months ago, it was recommended that the vaccine actually that all adults less than 60 years old get vaccinated for hepatitis B. And so I don't know why the cutoff is 60 years old. So I don't necessarily agree with that. I think everyone should be vaccinated for hepatitis B. So again, in my clinic, even it doesn't really matter why you're seeing me, but you're going to get hepatitis B serologies and then vaccinated if they've never been vaccinated. So that's kind of the bread and butter of hepatitis B management, but I'm going to just kind of shift and talk about bridging the culture gap, because especially in the States, a lot of the hepatitis B that we see is in Asian communities. And so I actually did my fellowship training at Tufts in Boston, which is actually located in Chinatown. And so every Wednesday we had an Asian Pacific Islander health clinic. And the vast majority was like 25 to 30 patients with hepatitis B. One of my attendings at the time, I was a fellow, she was a Chinese American, could speak Cantonese and Mandarin. And, I remember kind of being in that clinic, and it was so great because she really had this great bond with these patients and didn't have to use an interpreter or anything. So there is kind of, I think, something to be said about bridging that culture gap. So just kind of going through these definitions. So what is culture? So it's the body of learned beliefs, traditions, principles, and guides for behavior that are commonly shared among members of a particular group. So culture really serves as a roadmap for both perceiving and interacting with the world. And then ethnicity really refers to a particular social groups and complex societies. So groups differentiated not only basis of on a range of shared cultural content, but also on the basis of social attitudes and economic and political considerations. So why is culture important in healthcare? I mean, it kind of goes without saying, but culture really influences the powerful determinants of health-related behavior. And so not really knowing or being sensitive to health beliefs of different cultures can limit the ability to provide quality healthcare. And I see this kind of on a daily basis. And I think we saw some of it with kind of the mistrust with COVID and the COVID vaccine in populations that have previously, especially kind of our African-American Black populations that were previously kind of marginalized with kind of health inequity. And in addition to different kind of quote unquote experiments that were done with Tuskegee and other things. So I think there is really kind of important about knowing about these things and kind of where patients are coming from. And so this is actually a story. So this is Pauline Chen is actually a surgeon. And so she wrote a perspective, or maybe it might have been an editorial in the New York Times in 2009. And so she really describes her kind of experience with a family that had had liver cancer. And so this is actually her. I'm going to just quote a bit from that editorial. So one afternoon, not long after I finished my training, two sisters, both well-respected professionals in their late 40s, came to the hospital clinic. Both sisters had hepatitis B, and the older sister, like a fair number of chronic hep B patients, had developed liver cancer. She and her sister were hoping that we might be able to remove the tumor. I remember watching the sisters' faces turn grim as the younger of the two drew a family tree on the flimsy paper covering the exam table. Under each branch, she wrote out the names of siblings and parents, and I shuddered over the number of LCs, her abbreviation for liver cancer. The sister scrawled next to a name. It would turn out that the older sister's cancer was small enough to remove surgically. And a year after her operation, I ran into one of the liver specialists I'd referred the family to for regular follow-up. The siblings he cared for, I learned, were faring well. But what a pity, my colleague said, shaking his head. If only one of the clinicians I had seen earlier had been a little bit more aware of some of the health concerns of Asian Americans. So I think that kind of speaks volumes to know kind of what, knowing that not only hepatitis B causing liver cancer, but knowing that if there's a family history of liver cancers in the family, then knowing that those folks need to be screened a bit more aggressively. And so we talk a lot about cultural competency in medicine. So it's just knowing that patients' cultural background influences their healthcare, their health disparities and outcomes, communication and interactions with patients, and then the doctor-patient relationship and the experience of illness as well. And so what is kind of cultural competence? So it's the knowledge and interpersonal skills that allow providers to understand, appreciate, and work with individuals from cultures other than their own. It involves an awareness and acceptance of cultural differences, self-awareness, knowledge of the patient's culture, and adaptation of skills. And this is all to effectively deliver healthcare services. And there's also kind of patient perceptions of quality of care and a sense of hope. So communication is not just about language or interpreters. It is also being cognizant of what patients bring with them, right? So every patient that I see, we see has a story and kind of their own experiences with healthcare, good and bad, experiences of their family with healthcare, good and bad, and their own kind of histories going into just that encounter. And so knowing that story is so important sometimes, because it can really help break down the barriers to what they might be afraid of, or what they're, what they're frustrated about, or whatnot. But this is really hard to do. There are lots of time constraints. I get, 30 minutes for an invitation and 15 minutes for a return in clinic. So in addition to kind of, trying to address their main reason for being there, it's really sometimes hard to get down to the root of, especially if folks are, a little bit more hesitant to do things than others. But we know that cultural competence is linked to patient satisfaction. So this was a survey that was done looking at racial and ethnic minorities and found that they were less satisfied with the healthcare they received. And this figure specifically looks at the proportion of people who believe they would receive better healthcare if they were of a different race and or ethnicity. And so you can see specifically African-American and Latino populations in addition to Asian Americans. So it's definitely across the board that it's hard, especially if the provider that you're seeing doesn't quite understand where you're coming from or what you bring into that room. So I don't know who's read this book. If you haven't, it's amazing. So it's The Spirit Catches You and You Fall Down. It's written by Anne Fadiman, and she talks about and writes about a family, among family, and the parents and her child, this little girl who was diagnosed with a very rare seizure disorder. And they lived in California, and it was, them bringing her to kind of American medicine, and the doctors just not understanding the cultural kind of context of what where they were coming from. And so a lot of the things that the parents wanted to do were kind of traditional Hmong kind of remedies and things that they believed in from a cultural standpoint. So things, I think one thing that came up in the book was something called cupping, which is used in kind of a lot of Asian cultures as a release. And I think sadly Michael Phelps, I think, made it very popular during the Olympics, but it's very much used and there's benefits of it. But folks can think that that looks like almost like child abuse. And so there was a lot of kind of clash as the family interacted with the medical system. And I read it when I was in college, but really made me realize the importance of how important it is to kind of know a lot of where the family's coming from their own culture and their own experiences. So how do we do this? I mean, it actually doesn't really require having a lot of information, because there's no way we're going to know everything about every culture and every person walking into that room. But I think it does require some increased awareness. So there's cultural context of patients as well as doctors. There's awareness in self-critical ways. So like me walking in and dictating a plan, and the patient looks at me like I have 10 heads. And this sometimes still happens. It happened this morning. I'm actually on service right now, and I didn't even think twice. I just kind of went in and said what we were going to do, and there was a pause from the patient's end, and I knew there was something wrong, and so I asked. I took that time to kind of realize that there was something going on, and I wasn't getting to them, and it came out that they were very apprehensive of kind of everything that had happened until, but for them to get to this point, I mean, all the kind of the roadblocks that have been set in their way, and they weren't very optimistic that things were going to get better. And so also providers bring their own cultural orientations to the relationship. And so medicine really focuses on detection and treatment of disease, but not the experience of illness. So it's not that we're not insensitive, we're just not trained to learn the disease. We're trained to learn the disease process, not the experience of being ill. And the experience of being ill differs for every single person, and even within cultures. And so if we believe that if we treat the disease, the experience of illness will disappear, which is potentially possible, but if we don't actually realize that everyone's experiences of being ill are different than treating the disease, they may not even want the treatment for the disease. So cultural competence can be limiting, so it can really stop conversations. And we know that culture is fluid and it's important for patients and doctors. And it's not always important, but it's also, how do we do this? So we want to show an interest, affirm the person as an individual. So again, I try and do this in that 30-minute patient visit or 15-minute follow-up. I always try and find a common ground between me and my patient. So I ask about kids, pets, travels, foods, like their struggles. Like, I mean, Chicago had 61 days. What was it? 61 days, and we had 2 days of sunshine in those 61 days. So like we talk about stuff like that. And I feel like anything I can kind of relate to them, and there's somehow I can form a bond and be somewhat on the same level. But it's certainly not a checklist, but it's the ability to inquire and ask questions. And as much as cultural competency is important, I do think cultural humility is even more important. So cultural humility is really the ability to maintain an interpersonal stance that is other-oriented or open to the other in relation to aspects of cultural identity that are most important to the person. And so this requires a lot of self-humility. And so I can learn things, but I can't know everything, but I want to learn more. And when I make a mistake, I apologize, or I say I acknowledge that I don't know what they're talking about or where they're coming from, and for them to explain it to me. And so this is kind of the model for leaders in the 5 R's of cultural humility. So there's reflection, respect, regard, relevance, and resiliency. And these go into them a little bit more, which we'll kind of skip for the sake of time. So in terms of conclusion, so hepatitis B is a DNA virus. It's very common in Africa and Asia, but less common in the States. Importantly, though, it can lead to cirrhosis and liver cancer, even in the absence of cirrhosis. And then screening for hepatitis B is very, very important, as is vaccination. So if the one thing you take away from today's talk, everyone should be screened and everyone should be vaccinated. And then also cultural competency and humility are also equally important. And with that, I'm going to stop sharing my slides and I can take any questions.
Thank you so much, Dr. Sonali Paul. If anyone has any questions, feel free to put them in the chat. But I do have a question for you. The first one just being, what are the most common symptoms of hepatitis B that you believe people should be aware of?
That's a great question. So like most liver diseases, it's very silent. And so people only know that they have liver problems early on is if they go to their doctor and they either get liver tests or they get screened for hepatitis B. As it progresses and people can develop cirrhosis, that's when, and even early cirrhosis and early liver cancer, they may not have any symptoms. It's really when the cirrhosis becomes what we say decompensated, where they get almost into like a chronic liver failure, where they develop all the signs and symptoms and their liver really isn't working. That's when the symptoms come. So that's why liver disease is it's so silent and so deadly.
Thank you. And then another question. What are the most common misconceptions that you hear about hepatitis B, and how do you recommend addressing those misconceptions? And I know that misconceptions can vary between different cultures, but what common ones have you seen so far?
I think a lot of it is not, I think it's not so much a misconception. I think it's a maybe lack of education, of just not knowing that it's more prevalent and more in some communities than others. Specifically, I think from a provider perspective. I mean, I'm a hepatologist. I do this all day, so I'm very aware kind of what the prevalence is and who should be screened. But I think folks that are kind of prescribing immunosuppressive therapy, it's just not in their line of thinking or kind of knowledge base to know to screen patients when they're giving them these medications. And so I think as hepatologists, our job is to continue to educate the provider base. I think from a patient perspective, I think if you have providers, especially those that the patients feel connected with, that will listen to them and kind of treat or screen them for hepatitis B and do the right things. I think if it's coming from the provider, most of the time, my sense, my patients have been pretty receptive to getting screened, and if they have it, getting treated, or at least seeing a hepatologist for it. But I think having that bond between, because the hepatologists aren't at the front line, it's really the primary care docs. So having that kind of bond between primary care and patient.
Perfect. Thank you so much. But with that, I will share my screen really quickly. That concludes our webinar. So thank you so much for attending, everybody. We appreciate it. I just want to note that when you leave, there will be a prompted survey for you to just fill out. These questions are to better inform the work that our organization does and how we can support you with helpful webinars like this one. So that officially concludes our webinar. And thank you so much, Dr. Sonali Paul. We appreciate your time.
Thank you.